So welcome everybody. Thank you so much for joining us on the first workshop of this Health Partnership Capacity Development Programme. The key sessions for this sort of starter workshop today is really to have a thorough understanding of PHET's principles of partnership, but we'll also just do a little bit of revision of how they've sort of developed to form the best practice standards for our health partnership community and where that comes from. I guess one of the key reasons for doing this is as sort of the PHET grants team go through sort of bids for funding and things in the future, we really do believe that sort of stronger principles, stronger partnerships equal stronger projects, and this does usually come across in the documentation when submitted to apply for funding. And this SCCF funded project is all about hopefully building the capacity development of partnerships to be able to get funding to enable you to do more and more of your work. And then as part of this whole programme, we're really asking you to do some sort of self-assessment activities to see how you feel you align to the PHET principles of partnership. And this activity is as much the sort of learning activity in itself, as well as us going through some of the principles, really so you can form ways of having conversations across your partnership so that every member, both in the UK and overseas, hopefully have a real understanding, you know, of where the principles of partnership and therefore supporting your projects as you go through. And then we've got a little development action plan, which will help identify sort of areas for development to help us guide our support for you on where to go next. So some timing. So just going to do a little introductions now and just bring a little history of PHET and the history and the development of the principles into practice. And a lot of this day is all about breakout groups, discussions, having the opportunity to see how maybe some case studies link to the principles, and then also the second half of the day or the second half of the morning, actually even have a start of identifying how your partnerships link to some of the principles of partnership, and how to get started, with the form of the self-assessment. So hopefully lots of interaction into the second 2/3 of the morning. Great. So just to introduce ourselves, I'm Alice. So I've met many of you in our induction sessions, which has been lovely, the sort of one-to-ones. And for those of you that we haven't managed to meet, hopefully we will again in the future. And then Jessica and then Audrey, would you like to introduce yourselves?
Hi everyone, I'm Jessica and I'm a programmes coordinator here at PHET and working closely on this programme. So it's lovely to be here and to meet you all today. Thanks.
And good morning, everyone. I'm Audrey. I'm also part of the programs team, so I'm a programs coordinator and supporting Alice and Jess with these workshops. And yeah, I think I've met a few of you already on different workshops and projects, so it's really nice to see everyone today.
Ideal. So we think most of you probably know about PHET in the work, but there'll be a few who don't, and we hope that we've got some members of our partnerships from overseas. So a very brief sort of PHET in a nutshell introduction. So back in 1988, I think it was, that Eldred Parry founded Tropical Health and Education Trust. Eldred founded the Tropical Health and Education Trust, and I think this was particularly on sort of back in 1988. He was ahead of his time, sort of after noticing a year in Nigeria that British aid was not particularly responsive to needs as decided by the countries themselves. So he set up PHET, and it's still working very much to support the fact that 1 billion people will never see a qualified health worker in their lives, and we're very much working to change this, but very much doing it through this sort of partnership-based approach, using a model for improving health services by linking hospitals, clinics, health centres in the UK with their counterparts overseas. Is that in the last 10 years alone, we've reached over 100,000 health workers across 31 countries in Africa and Asia, and in partnership with over 130 UK institutions. So although we've obviously got the health partnerships such as yourselves that we support in many countries. THET does also have country offices for running some other programs in Uganda, Tanzania, Zambia, Ethiopia, and Myanmar. And, through these country programs, supporting a range of capacity development programs working at sort of different levels of the health system and different cadres of health worker and institutional partners to support the training of health workers and strengthening of the health systems they work in. And there's many of these specific projects actually are slightly different to the health partnership work that happens from sort of maybe the health institutions in the UK across, and there's lots of information about them on the website. The latest campaign, I'm just going to mention this because obviously slightly devastatingly, due to the COVID pandemic, the government have really feel they've had to cut aid spending by 4 billion, which is rather devastating. And we as THET actually feel that this is really going to cause a lot of damage to the world's sort of most vulnerable individuals, and really trying to work to support the fact that we need to be looking at sort of equity and really trying to advocate for our continuing work overseas. So if anybody is on Twitter, there's a HEAL campaign, so very much about health equity for all that you'll be able to keep an eye on. And we're hoping that this sort of advocacy and campaigning will help ensure that the aid budget gets increased again, and that our opportunity of having funds to support our work is able to continue. So what we're going to do now, just before we, just probably for 15 minutes, I'm going to try and do about 16 years of policy in less than 16 minutes, I think was my phrase, but very much about where the THET principles of partnership come from in their sort of evidence-based approach. So they weren't just sort of written up overnight, they actually do come from a sort of policy background into the principles, and then we'll move on very much in the next stages and in the rooms where we can all discuss about how we're putting the principles then into practice. So a very quick little bit of history. So this is where I think Eldred back in 1988, seeing that maybe the decisions on how the sort of aid was supported he was a bit ahead of his time, because it was not until 2005 that there was actually a Paris Declaration on Aid Effectiveness, looking that aid should be producing better impacts than it had done previously. So there are about 34 countries, I think, from the OECD group that came together and decided that really aid should formulate around 5 central pillars, being about ownership and developing countries setting their own strategies for poverty reduction and sort of improving institutions for corruption and things, and that we should very much be in alignment with those, so that donor countries align behind these objectives and very much use local systems for the local development. And then obviously the fact that there needs to be harmonisation between all the sort of different donor countries and donor organisations and institutions, and to sort of share information to avoid duplication. Donors and partners need to be accountable for the development results, and sort of mutually accountable as well. So you'll be able to sort of see these words and these terms in our hallmarks of practice and hallmarks of the principles when we get to those. So after Paris, these were reviewed and reaffirmed in Accra in 2008. There was even a greater call for partnership working at that point between different parties working on aid and development. 4 main areas for improvement from that particular review were about ownership, inclusive partnership, delivering results, and capacity development. Reviewed again in 2011 in Korea with the question of, is aid being delivered more effectively than in 2005? I think the answer I managed to read about was that progress has been made, but there were no targets set at the time. But again, it was very much that it was about global partnership for effective development and cooperation was endorsed. So another key area, and again, you might well find that this is mentioned in many grant applications, particularly those to do with global challenges, development funds, and others, about the Sustainable Development Goals, which very much took over from the Millennium Development Goals back in 2015 with a vision of 2030. It's been adopted by all UN member states in 2015 and providing a shared blueprint for peace and prosperity for people in the planet now and into the future is the sort of strapline. Goal number 17 is in fact, strengthening the means of implementation and revitalising global partnership for sustainable development. And as the WHO, I rather like this infographic where the WHO have put health at the centre, but very much suggesting that it's an intersectoral aspect and that we need to think of the goals as a systems change. And I think that comes into that whole health system approach that we're trying to take with all of our work. And again, very often, funders might well be asking how your project makes an impact on particular goals of the Sustainable Development Goals. So if you, by any chance, haven't come across them yet, it's certainly worth looking them up. So just moving on, so Lord Nigel Crisp, who I believe is actually the patron of FET, but back in 2007, this was, so a while ago now, Tony Blair commissioned him into looking at sort of global health and the contribution of the UK to health in developing countries. And this report, Global Health Partnerships, acted as a call to the UK health system to scale up and coordinate its engagement in global health. And it was really the launch pad for a huge amount of the work and the ongoing support and funding that has followed. And again, if you haven't actually read it, it is worth a read. So much has flowed from this. It's when the NHS International Health Group came into existing at a time, being tasked with taking a strategic approach to how the UK engages in global health. And then funding for partnerships followed in the form of International Health Links funding scheme managed by the British Council and FET. And then the funding scheme became larger, more ambitious for the Health Partnership Scheme. And then obviously this was extended, and then there was this great plan for the UK PHS, so UK Partnership for Health Scheme, which was in place and due to be funded from 2019 to 2023. Although unfortunately, as we realised, the repercussions from the COVID pandemic has meant that this funding has now been withdrawn. However, we do have positive news that I think there's reason to believe that health partnerships will continue to feature strongly in the next government strategy on global health. And therefore, we would have great support and hope that there will be future funding available. So also over this time, there have been various APPGH documents produced. The all-party parliamentary group, Global Health, Improving Health at Home and Abroad. There's also been an NHS International Health Group engaging in global health. These are both quite old now. That was 2013, 2014, specifically looking at the NHS contribution and sort of setting out national quality standards for engagement in global health. And there's lots of ongoing work, and it's really building actually with the sort of health wellbeing benefits to the NHS, as well as benefits to hopefully our partners overseas from this work. And again, I'm not going to go through all of them, as you'll be very pleased to hear, but the various documents come out from APPG, and the latest in 2021, ready for the Cornwall Summit, it was still about co-development, partnerships, mutual learning, recommended for the new UK Global Health Strategy. So obviously these aren't government documents because they're the all-party parliamentary group, but there's still great hope that we are very much working in the right lines and following the sort of policy documents, and also forming it by our work and our lessons from what we're doing. So the health partnership model, long-term sustainable institutional relationships between health institutions in the UK and their counterparts in low and middle income countries, often working to provide discrete tailored projects. I think original plan was a sort of usually 1 to 3 years, but actually we're finding that obviously more and more partnerships can go on for many years. Although one of the hallmarks in, I can't quite remember which principle, it might be strategic, that actually often with the individual projects, there does often need to be an exit strategy and what does success look like to ensure that the sort of there is the potential, sort of sustainability of handing over or creating change that lasts without input. But and again, as we've talked about, evidence is supportive of the fact that partnerships and projects are mutually beneficial, with benefits also coming back to the UK NHS and wider health and social care system, as well as personal benefits to participants of partnership work, as I'm sure we're all aware. So there were originally 8 principles of partnership that FET wanted to ensure were embedded across all programmes and partnerships. And then within the last 18 months, there's also been the addition of embedding GESI, so gender equality and social inclusion, across all programmes and partnerships. So these 9 principles underline our partnership model. Each is accompanied by a hallmark of good practice, which break them down into what could be considered as maybe performance indicators. And Jess and Audrey are going to present one principle each now and their hallmark to discuss how you might understand these in a little bit more depth. And I don't know if people have had a moment to be able to go onto the Pulse platform and have a look at the recording that's going over some of the others, but if not, there is a recording with a bit more information on some of the other principles. We're not planning on talking you through absolutely all and every one of them now.
So the first principle that we are going to look at this morning is the principle titled Organized and Accountable. And it's outlined by hallmarks of good practice that you can see on your screen now. So as Alice mentioned, the hallmarks are indicators which partnerships need to meet to be able to reflect the relevant principle. And it is important to keep these hallmarks in mind, especially when you submit a proposal or a grant application, because SET usually asks partners to reference these principles and these hallmarks throughout the application, and referencing them will make the application stand out a bit more. So in terms of the hallmarks of good practice for the organized and accountable principle, there are a few that I'm going to go through now, but there are many more that we can also include in that principle. So partnerships, for instance, should have a clear and stable governance structure, and they also should avoid being over-reliant on individuals, which is quite risky in terms of sustainability of the partnership, but also of the project that they are working on. It is also important that individuals with the appropriate experience and expertise are engaged in the projects, and that roles and responsibilities are clearly and equitably shared. So this is something that we usually flag in grants applications when we are reviewing them. We usually have to request some additional information on the roles of each partners to make sure that each partners involved in the project are clearly involved, engaged, and supportive of the project, and that they have the capacity to be involved throughout. And we also sometimes have to flag that the projects seem to be overly led by one of the partners. So it's important that all partners are clear on what is expected from them and what their roles and responsibilities are. It's also important that partners develop and use a clear communication channels. So this could be through internal team meetings on a weekly basis, for instance, daily email check-ins, or even creating a WhatsApp group to discuss project issues. So these are some examples of communication channels that we have seen in project and that were really effective and successful. And it's also very important that partnerships develop a set of policies, processes, and strategies that are tailored to their partnership and also to the projects that they are working on. So this could be through the processes that I will mention now, but there are many others that you could implement and that could make your partnership more organized. So partnerships need an effective fundraising strategy to make sure that the partnership can find and sustain multiple sources of income, and also to ensure that the partnership can receive financial or in-kind support from both partners. Another important process is a transparent financial system with shared accountability for financial monitoring. And when it comes to donor-funded projects, there is an expectation that all transactions are monitored evidence and report it to the funder. And for instance, with that, we usually require that grant holders complete a financial report, usually biannually or at the end of the project, with a list of expenses, and we spot check some of the receipts. But a lot of donors will request to see all receipts and all invoices for all expenses. So it's important that partners have the same or similar financial systems in the UK and also in the LMIC countries to be able to manage this and keep evidence of everything. Procurement processes are also very important to minimize costs and to ensure that the value of money of the products and the equipment procured. And this could be, for instance, through requesting 3 quotes for equipment to 3 different providers, comparing the cost into a spreadsheet and then going with the providers that can provide the best value for money and also that makes most sense for that specific equipment or specific project. And this will ensure that you have a transparent procurement process. And then processes around effective volunteer management should also be developed and reviewed on a regular basis, as well as emergency protocols, and especially when volunteers are traveling internationally to provide in-person support, and especially during COVID-19. And finally, partnerships should also make sure that they keep records and reports of significant activities, results, decisions, and transactions, and that they share them as appropriate with all partners, stakeholders, and funders. And again, keeping records of significant activities will make it easier for you to report to funder on a quarterly, biannually, or annually basis. And this will enable partnerships to provide accurate and transparent data throughout their projects. And we wanted to highlight a case study to give you an example of good practice. So we wanted to mention the partnership between Central and Northwest London NHS Foundation Trust and Mirembe Hospital in Tanzania. They have been working together since 2010 and mainly on projects related to substance misuse through SET. And throughout the different projects, they have carefully planned the partnership's governance structure to include committees with broad membership, accountability to senior management in their institutions, and champions responsible for different strands of work. So for instance, one of their programs had 4 different strands of activities, and therefore they decided to allocate one coordinator and Mirembe for each strand of work. And they also established clear reporting and decision-making processes with monthly meetings involving the 4 coordinators, along with the overall Mirembe program coordinator, the program accountant, and the hospital superintendent. And this partnership had also appointed a Tanzania Link committee in the UK. And this committee had overall responsibility for the program, and it involved a multidisciplinary team with individuals with managerial and clinical expertise. And this committee met monthly. They had also set up a number of different subgroups to deal with specific activities or specific issues. And this committee was directly accountable to the trust board, and they were required to present the progress report to the board on a quarterly basis. And they also had a trust board non-executive director sponsor in the UK. So this clear governance structure from these partnerships was established from the early days of the partnership, and it ensured that more detailed knowledge of each program strand was held with the individual coordinators, but also with the members of the committee. And this helped them reduce the impact of key personnel leaving and reduce the reliance on one person only, which can be a bit risky in terms of accountability and also sustainability of projects. And now I will hand over to Jess for the next principle.
Thanks, Audrey. So yeah, the next principle we'll touch on briefly now is responsible. So as you can see, there's the hallmarks of good practice here. So for example, partnerships, keeping up to date with current advice, adhere to international guidelines and best practice for international development. So that's a key one that we, in applications that we're reviewing, that we really look for, that the partnership has considered international guidelines, international toolkits that they can use to inform their practice and their project. So we want it to be their projects and their approach to be built on strong evidence and kind of adhere to good quality guidelines. So that's something we really look for, and shows that the project is being responsible and exploring that and ensuring it's included in their projects. Another one, key one, being the partnerships are open to admitting mistakes and reflect and respond appropriately. So I'll talk through a case study in a minute that talks about this, but that's a really important one because there's so many things that can change and a lot of unknowns sometimes when you're starting a project. So the fact that you can be open about any mistakes you make and try and think about how to tackle those and lessons you can learn from it is a really important aspect of the partnership, showing responsibility for their actions and approach. And then you can see the other ones here. So being honest and respect for others in the partnership, and also all the stakeholders they're working with. All those participating in the project activities comply with relevant professional codes for health workers. So again, really important that quality and standards are adhered to by the partnership and really promoted. And then thinking about risk with the project activities. So this might be through a risk register, but also going a bit further and making sure that the partnership is really acting and holding the duty of care for all those that are involved. So all the volunteers and project team and anyone that's involved in the project and partnership. So I'll now touch upon a case study on the next slide, which is looking at the specific hallmark of admitting to mistakes and reflect and respond appropriately. So the partnership between the Association of Anaesthesiologists of Great Britain and Ireland and the Department of Anaesthesia at the University Teaching Hospital Lusaka, Zambia, was originally established to develop a postgraduate anaesthesia training program at the university. The need for the THET-funded project arose when it became clear that serious deficiencies in patient care would continue unless the systems used by the clinical staff was improved. So the project aimed to improve perioperative systems, focusing on sustainability and increasing capacity for safe anaesthesia care. So they would do this by developing the skills of local staff, patient safety, education, and leadership. So learning from this project, the partnership spoke openly about the shortfalls of the project and highlighted the problems that the partnership encountered specifically in their monitoring and evaluation of the project. And they identified lessons learned from this and advice for other partnerships. So one specific problem that they identified was that the UK partner had assumed that data that they needed to collect would be available and accurately recorded at the hospital. So the partners had not really given consideration to the practicalities of collecting data to demonstrate a decrease in the perioperative mortality rate. So their overall goal was to decrease the mortality rate, but what they realized was that it was hard to measure this at the start and end. Like how would they show the mortality rate? So they wanted to establish a baseline before the partnership intervention started, but they found that collecting data was much more difficult than anticipated. So they found that a huge amount of data was missing. Many things were recorded inaccurately. It was almost impossible to establish a baseline of mortality rate because the theatre registers and mortuary records were inaccurate, which meant that demonstrating a decrease in mortality rate would not be feasible. Furthermore, the partnership realized that they hadn't budgeted for data collection or analysis, and a lot of it was done in quite an ad hoc, rushed way. So it became difficult to meet the demands of data collection. It found that it was really time consuming and required a lot of input from people that had conflicting priorities. They also found that data analysis took longer than expected and it was difficult to find budgetary and human resources midway through the project. Therefore, the partnership learned from this mistake and discussed it as a partnership and decided to change their overall goal to improved service, which meant they could think about how they could measure this more feasibly and more accurately. So they felt that because in doing this, in terms of changing their goal and thinking about how they could do the data collection more feasibly, they felt that it was important that the baseline mortality rate was still looked at. And in doing that, they were able to collect data that enabled patient notes to be analyzed in detail and discussed with the surgical teams. And the partnership also involved staff in other departments of the hospital, which enabled them to understand common avoidable causes of mortality and gaps in record keeping, as well as identifying other departments in the hospital that needed this support. So in terms of taking responsibility for these mistakes and lessons they had learned, they decided to highlight the advice for other partnerships, which was to gather and analyze data early on in the project, to review the relevance of your indicators, the partnership's indicators. And this will help partnerships to assess the feasibility of collecting data to evidence your objectives with the resources available. So your time, finances, and skills available. So this is one example of a partnership taking responsibility and learning from their project, and then taking that advice on to improve their project in the future. I will now pass back to Alice.
Great, thank you, Audrey. And yes, hopefully I've restarted my audio and visual. So you'll be pleased to hear that it's time for